morning, respected judges. My paper is on a modified combination therapy strategy for polypoidal choroidal vasculopathy. No financial interests or disclosures. Now, polypoidal choroidal vasculopathy accounts for nearly 50% of patients supposedly diagnosed to have wet AMD in our practice. The expert PCV panel has put forth diagnostic criteria, and this is basically based on ICG angiography and clinical findings. Though there are many treatment protocols which are suggested, Everest study was the first study which came out with the recommendation that combination therapy or PDT monotherapy is superior to anti-VEGF monotherapy in achieving good vision and anatomical outcomes at 6 months. And this is now considered to be the current standard of care. However, in practice, PCV patients often present with significant associated hemorrhage and fluid, which may prevent a good response to initial PDT, and this could be the reason for poor response in some eyes. We believe that drying up of the fovea initially before PDT may be a better way to treat these eyes, and we call this approach the deferred PDT. Now, the aim of our study was to evaluate the efficacy of a modified combination therapy protocol using the deferred PDT approach for polypoidal choroidal vasculopathy. It was a retrospective study including patients who were diagnosed to have PCV on the basis of ICG angiography, who underwent this modified treatment protocol and followed up for a period of at least 1 year. This was a modified protocol. After the initial diagnosis, patients received ranibizumab injections monthly till the fovea was dry. At this point, a repeat ICG was done. Following this, a combination therapy of standard fluence PDT with the ranibizumab injection was done, and then patients were followed up at monthly intervals with the SDOCT. Anti-VEGF therapy was added when there was a decrease in visual acuity of 1 line or more, when there is presence of subretinal fluid or appearance of new subretinal hemorrhage. PDT was added when there is no response to additional anti-VEGF therapy over 2 visits. These were the exclusion criteria. Statistical analysis was performed using the SPSS version 17. These were the baseline characteristics. We had 25 eyes of 24 patients. The mean age was 70 years. There was a slight female preponderance. The baseline visual acuity is around 0.4 logmar, equivalent to around 64.9 ETDRS letters. We used a conversion formula to convert the Stendhal fraction into ETDRS letters, and we found that at 6 months of follow-up with this modified combination therapy, there was a statistically significant increase in the ETDRS letters, which maintained through 1 year of follow-up. Again, with respect to central retinal thickness, there was a statistically significant decrease at 6 months, which maintained through 1 year of follow-up. Now, the average number of injections received before PDT was 2. There were some instances where patients received up to 4 injections. The average timing of PDT was around 4.6 months. Now, the mean number of retreatment with anti-VEGF injections at month 6 and month 12 were 0.6 and 0.7 respectively. Only 1 patient required additional PDT over 1 year. Now, these are some of the representative patients here. These are patients with the branching vascular network and polyps who received anti-VEGF therapy initially to dry the fovea and later underwent combination therapy and maintaining relatively good dry fovea at 12 months of follow-up. These are patients with polyps who seem to do better than the group which had BVNs. We also did a subgroup analysis. We had 19 eyes who were treatment naive and 6 eyes who were previously treated. We tried to compare these two groups. Though there seemed to be a difference, it was not statistically significant in terms of visual acuity or even in terms of central foveal thickness reduction. The mean number of injections was slightly higher in the previously treated group, but it was again not statistically significant. We also went on to see if any variable could predict better outcome, better visual or better tomographic outcome, and we found that baseline vision was the only variable which seemed to have a correlation. A baseline visual acuity of less than 624 was associated with a good visual outcome at last follow-up. We also tried to compare our study results with the Everest study combination therapy arm, and we found that the average number of injections for retreatment and the number of patients retreated with either injections or PDTs was less in our study compared to the Everest arm. We also compared our study with the Fujisan study, which also had a delayed PDT group, but with a different protocol. Here again, we found that the percentage of patients receiving additional treatment and the number of injections received was much less in our study when compared to that study. Now, combination therapy of PDT and anti-VEGF drugs provide the complementary effects of both treatments, but it remains unclear whether PDT would be beneficial if administered at the beginning of treatment or during follow-up of anti-VEGF therapy. Our study is different in this aspect because we observed that drying up the fovea before PDT will give better anatomical and visual outcomes. We believe that there is better delineation of the polyp and BVN, there is better therapeutic effect of the PDT because the lesion size is smaller area needs to be treated, and there is lesser chance of complications like RIP. The number of additional treatments required were also less. The major limitation of our studies is it's non-comparative, it is retrospective, and regression of lesion on angiography is not studied. To conclude, deferred PDT combined with anti-VEGF therapy in PCVIs show good visual and anatomical improvements at 12 months. It leads to significantly fewer additional treatments and less complications. These are my references.